Good afternoon, everybody, and welcome to the Strengthening Medicare Taskforce Report community briefing. Elizabeth Deveny, our CEO, is going to take you through the Medicare Taskforce Report, but she's just caught up on something. So we might just go through the housekeeping and some other issues before we start with Elizabeth. First of all, I'd like to acknowledge the traditional owners of the lands on which we're all meeting and living and working today. We're on the lands of the Ngunnawal and Ngambri people here in the ACT, and I'd like to pay my respects to elders past and present and those yet to come, and to any Aboriginal and Torres Strait Islander people who might be on the webinar today. So welcome to everybody. As you can see from the opening slide there, please share your name in the chat, and if you're representing an organisation. We'd love to know whose country you're on, so put that in the chat as well. If you could put your actual questions that you want Elizabeth to address in the Q&A rather than the chat, that would just help me in monitoring the questions, and the chat can be where you pass a view or pass on comments, always making sure they're respectful of everybody else who's on the webinar. And we will be recording the webinar and we'll send it out soon after completion. So thank you for paying attention to those and the rules of engagement, if you like. And now we've got Elizabeth, so I'm going to hand over to you, Elizabeth.
Thanks so much, Jo, and welcome everyone. I think we've covered off on the housekeeping, so we can move along to this session proper. I heard you acknowledge country, Jo. I just also like to do that. I'm also on Ngunnawal and Ngambri country. I'd like to acknowledge the traditional owners of the land, pay my respects to them, acknowledge their continuing relationship to this country, and thank them for the opportunity to do our work in this space. There's really two sections to this presentation and conversation. The first, we're going to run through at a high level the task force process and the outcome, and then we're going to talk a little about where to from here. We will stop from time to time for your questions, so we encourage you to put them in the chat, noticing that we might not get around to them all, but those that we don't get around to responding to in today's conversation, we'll certainly pay attention to, and hopefully if you've got a specific question, one of our team will be able to get back to you in the near future. So the task force, this looks like the task force I would have liked to be on this table here actually, but if we move along, this is the task force itself. There were 16 participants in the task force, the Strengthening Medicare Task Force. Consumers Health Forum was there to represent the voice of Australian health consumers, and there were the majority of the other members of the task force were representing clinical organisations, and then there were a few other people there representing other particular perspectives, such as universities. The task force's job in part was to provide the Minister with some advice about how to spend $750 million, which has been allocated to improve how Medicare works. Some of this funding will be allocated in the May budget, so there was a time pressure here. Many of you will be familiar with the time cycle for federal budgets, so this conversation needed to happen in time to influence the advice given to government about how to spend that money. Our new Minister Butler, was very keen to hear from everyone and understand the current state of play. Where did people think there were opportunities for us to improve Medicare? In the past, certainly in the past few years, there's been a lot of consultation about primary care. Many of you would be aware of, and indeed will have been involved in the extensive consultation that occurred in the development of the 10-year primary care plan. So all of this was taken as read and used as part of the foundational understanding that we came to the table with, understanding that these issues, they're not new, they're not 2 years old, they're not 5 years old, they're decades old, and many times communities and others have been asked what to do, and advice has been provided to government many times too. The task force meetings themselves, there were half a dozen of these. They took the format, as you can see, it's a very big table, of the minister having some key issues that he wanted to explore on the day. He'd ask us a question, and then there would be a pretty rigorous debate across the table, with everybody chiming in with their experience, with what they'd heard from their consultations. And then we'd wrap that one up, and sometimes a single question could spark a 90-minute conversation about a really important topic. We would go quite deeply into that topic and learn and share, and then we move on to the next one. That information was then used to help the department prepare the report for the minister on the deliberations of the task force. So that was really the process itself, and it was certainly a very interesting process to be involved in. The task force report was published on the 3rd of February, just a couple of days after, I think the minister initially said that it would be provided in January. But then there was a federal cabinet meeting in early Feb, and that was a good opportunity to share that information from the report with the jurisdictions, because clearly health is everyone's business, and all governments fund health in some way: local, state, territorial and federal. So there is 4 key recommendations in 4 key areas for recommendations in the task force report: increasing access, encouraging multidisciplinary care, modernising primary care, and supporting change management. And I think the last one is the one that has in the past often been underdone or missed. This notion that if we're going to ask thousands of general practices, Aboriginal controlled health services, physios, pharmacists, nurse practitioners, osteopaths, you name it, everybody, consumers, carers, community leaders, to change the way that we run our primary care system, because health's the people business. We're the ones that really make up the healthcare system. There's a lot of change management, a lot of support that needs to be provided in order for this to occur. Often organisations are only funded to deliver a service, whatever that service might be. They don't have funding to manage change, particularly smaller organisations. So to my mind, having this on the agenda, and we all agreed so important and often a missing part: how do we build capacity? How do we ensure that the appropriate health literacy resources are available? How do we make sure we've got a mechanism for understanding how the changes are being made and adjust as we go? I'm a big fan of iteration. Pilot it, have a beta, and then keep going, working through till you finally get something that works for most people, though we accept a universal system is never going to be ideal for everyone. Now, as I said before, none of this is surprising, and I think that's some of what we've heard in the media. This is not a surprise. Well, with the same problems, we should expect the same solutions, but I think that's also why there has been largely a sense of frustration, like we know what needs to be fixed, could we just get on with it and fix it? I think is a theme that certainly from feedback we've had here at CHF has been widely felt. So this kind of more of the same, and you will have seen it yourself in various news articles, Twitter and so on. Lots of political conversations about whose job it is and who caused the problem, who's got to fix the problem. We would say, and we recently did a bit of a tidy up in our office, and we've got reports like this that date back 30 years. I could show you a stack of them, all pretty much saying, here are the problems, and then here are the solutions. We've seen that war between disciplines continue in the post-task force period, but interestingly, not much conversation about consumers, particularly not consumers as active participants in the process, as decision makers in where things should go. So a lot of the conversation about, what a GP should be paid, and we would say that's important, but more important for us is affordability for everyone. And as long as health services are affordable and ideally as much as possible free, then the system will be accessible and universal. How governments choose to solve the affordability problem is something they can negotiate with our clinical colleagues. But from our perspective as consumers, we want to have access, and part of access is always being able to afford the care. So we've had a little bit of conversation actively, and particularly just before the report was announced. CHF went out through our survey pool. We've got a large pool of consumers that complete surveys for us. We sent one out in December saying, okay, this task force report's coming down now. What do you want? And this is what people said. These were the top 10 issues that, and many of you may have completed that survey. If you did, thank you so much. These are the top 10 things that people said they really wanted to see in the report. Again, as you look through it, none of it's probably surprising. It's reinforcing things you might have said before or seen before. And this is what we put out to government and broadly in social media before the report landed publicly. When it did land, we had a look to see, well, how do we go? A bit of a scorecard. And you can see that from this 10-point action plan, there were a few wins for us. So the next slide will show you the 10-point action plan, and you can see that some of these areas have been addressed. Maybe not as holistically as we'd like, but to be honest, the funding hasn't been allocated, the budget hasn't been had. And until that happens, we really won't have enough detail to see how well these areas will be addressed in the coming years. So it's pleasing to see that a lot of the issues that many of you raised and your organisations raised on behalf of all Australians were taken into consideration in the report recommendations. The next question, of course, is what does that mean? How does this actually translate into action? And, you know, as we say in the slide here, you know, words are good, but what we actually want is change. And I think we're all ready for it. And for many of us, it's becoming more and more important that this change occurs. The current economic situation in Australia, we know that many people are finding it more and more difficult to afford all kinds of things, not just medicines, you know, housing, petrol, and school fees, whatever it is you've got to pay. And we know, and our research tells us over many years, that when things get tight, many Australians make decisions to not look after themselves. That is, to not get their medicines dispensed, or not to see the GP, or not to have an expensive investigation because they cannot afford it. So we really need that action, and we need it soon. So we're hoping that what we'll see in the upcoming budget is some significant improvements and some action based on the common sense that's in this report. Now, I'm going to stop about here. I can see there's a few questions in the Q&A, Joe. What is it that we might want to talk about now?
Well, there's a question from Anne Lawless, which I think is probably a key one, which is, was the report focusing on primary care or primary health care? Because often there's quite a distinction. I wonder if you wanted to just clarify that.
Yes. Thanks very much for the question, Anne. I'm just wondering if you're a Barbara Starfield fan like I am. And the answer would be really primary health care. We didn't look more broadly at primary care. It was really about that $750 million on Medicare in the budget. What are the things the government could do now that would help ease the pressure on the system and on all of us?
And I mean, and I just need to apologise to everybody because the chat's not working, so you'll have to use the Q&A as chat. So I'll monitor your questions in amongst the chat. Jenna's trying to get it to work. There's some people sent some questions in beforehand, Elizabeth, and a couple were around what sort of the scope of the task force work was. Was it going to be able to recommend funding models away from the current fee for service, or was it just confined to tinkering at the edges? I think sums up a couple of questions that we got.
Yes, so it was more than tinkering at the edges, and you know, $750 million sounds like a lot of money, but actually when you think about it across 25 million people, many of whom have significant health needs, it's not very much at all. So the question for this task force was, given that that's the bucket of money we have, what is it that we can do? And I think what you can see in the recommendations is this notion of wraparound care, and that wraparound care would be, you know, bulk billed or freely available to people. our hope would be that if that model, or models as it may well be, come quickly into implementation phase, for people where those services are available, they will be able to get the care they need from a multidisciplinary care team. And it might also cover off on some social care needs. You might have in the team, for example, a social worker, so that people are less reliant on the current fee-for-service Medicare system, where you may well have a co-payment. So we saw, and again, this has been done in Australia in various ways. If we look at the Aboriginal community control sector, there's lots and lots of lessons and really brilliant work done there in how to manage people outside of the Medicare system when they do need comprehensive, coordinated, multidisciplinary care. So we have the answer. This is how we can do it. And then the question is, well, how do we fund it in such a way that we don't rely on individual Medicare items? And some of you will be very familiar with Medicare and know that a lot of it relies a doctor to be the person performing the action. The intention of this wraparound care model is that the money is provided for workforce. Those people can do their job as they are trained to do, and we don't need to, kind of clip the ticket every time with a GP to have an action performed and then funded. So I'd hope that if this multidisciplinary care that's funded through that model actually does get up, that it will actually ease pressure on people who are right now struggling to be able to both access care, and if they can access it, to afford that care.
There's a couple of questions, I guess, about some other developments that have happened. One is around how does the establishment of the new urgent care clinics fit within the work that the Strengthening Medicare Taskforce is doing? Can you answer that one?
Yeah, so the urgent care clinics was noted by the task force, but they're being set up by an implementation team within the department. That team wasn't present. I think perhaps the senior official was there, but the team themselves were not present, and they didn't present to any of the task force meetings. So the task force wasn't kind of deeply briefed on those urgent care centres. This was an issue that CHF raised actually in their response to the October budget, where we said there's a lot of different models of after hours care being funded in that budget. We can see there's an issue with after hours care. Some of that is urgent care, some of it's convenient care, some of it's because there's no care at all of any kind that people can access. And I think, again, for us, we know that Australia has a world-class healthcare system. We're told that all the time. It's just impossible to find your way around. So we're really keen to see that where we are putting new programs in place, and the urgent care centres are a really good example of that. How do they fit into everything else, and how do we know how to navigate from one to the other? We did talk about the navigatability, what a word that one is, of the Australian healthcare system, and say that we did see that was a key issue that needed to be addressed, but I don't think really within the remit of the task force, though, maybe that's one where some reform might help there.
So and I guess a related question, which really is all about the scope of the task force and what came into Strengthening Medicare, seems to be what's coming through the questions. Was there any discussion about procedures that are not covered by Medicare, which consumers have to pay for? Changing
No.
what can be covered?
Yeah, Jo, we didn't really go into that space at all. It was very much about kind of everyday clinical care in a practice setting. I say practice, but it wouldn't have to be bricks and mortar. It might be a nurse practitioner going out to a community, for example, rather than someone coming into a metropolitan general practice. But it was very much about, particularly chronic disease management, because that's where, often people are experiencing the most issues around access, where people do need regular and sometimes timely care, versus someone who perhaps, I don't know, sometime in the next 4 weeks needs to get travel vaccination. We didn't kind of focus on that, nor did we focus so much on preventative care, other than to say that primary healthcare was a great place for that to be delivered.
And I think the other questions that we've got probably relate to, there were questions around affordability and, was affordability a big focus of the task force, and what was it really recommending could be done to make primary healthcare services more affordable for people?
Yeah, so I think this came back to, well, there is a group of people that are really impacted by affordability issues and access issues, and those are the people that most need our help in the reform of Medicare. For people who are well and only occasionally need the fee-for-service model that Medicare provides, it probably works okay for them. Now that the co-payments perhaps in their local general practice have increased, that might create some challenges, but if you're seeing a GP, once a year, it might still be doable for you. Whereas people who are having to see a GP or, whoever their local care provider is every week or every couple of weeks, this is much more challenging. So again, we say that wraparound care for those people who need it most, which is provided free of charge through a multidisciplinary care, will help address that affordability issue and that access issue.
Simon Gould raised a question which I think he raised to us previously and has raised again, which is that he made a comment that he thinks the report's quite naive and doesn't really address the fundamental problem of fee-for-service. What would you respond to that?
Thanks, Simon, for your comment. They are the same answers to the same problems, but in part, I think that's because they are the answers. So Medicare, when it was set up, was designed to be universal healthcare. Now, I don't think we can say that it is, because the issues around access are so significant. And given that we don't have unlimited resources, particularly in terms of health professionals, we don't have a machine that just churns out experienced and readily available healthcare professionals. And I'd say, thank goodness we don't. That means that we have to look at the current system and looking at how we can move it quickly to do a better job under, existing situation. I don't think that I know the comment about, and people will say this like kind of 6 minutes medicine. There is certainly, some people will argue that it's about churn rather than about keeping people well. And I think that can be the case somewhere, but it's not the case everywhere. So it's not always my experience that I feel like I've been in churn. I certainly have had that experience. I think fundamentally, though, all of the people around the table think that there is an appetite to move at least in part away from fee-for-service, but we recognise that for lots of reasons, a big move all of a sudden is not going to work for anyone.
Tara and a few other people have asked, who was around the table? I guess these are people who we sort of assume everybody knows who was on the task force. Can you give people sort of flavour of who was on the task force?
Oh, I'll do my best. So there was kind of a rural crew representing Aboriginal controlled health services, rural generalists and the like. And they were often very vocal about the differences between rural, remote and regional care, and also the terrific models of care that are in place in some parts of Australia and the gaps in others. There were several organisations representing nursing in various forms there. There were also people who were representing allied health professionals and practice managers of general practices there. There were then organisations that represent doctors and particularly GPs through the Royal Australian College of General Practice. And, I'm definitely going to forget at least a couple, and that is, that'll be me, no doubt, being asked later to explain why I forgot someone very important. And then there were a couple of other people. There was someone, a health kind of economist, and I've probably got his discipline wrong. They're talking about the kind of system piece and the costs more broadly. And then there were a lot of public servants, as you might see in the photo, and senior public servants, both sitting around the table and also sitting at the back of the room, listening to what was being said and taking notes of the key issues raised by everyone. That was really who was around the table. So very clinically focused.
I think that covers off most of the questions on this part. And so did you want to go on with your slides now?
Yes, sure. Happy to do that. If we move on to the next slide now. So, yes. So I think, this is the question: how will the money be spent? And what we know and what we can see strongly is that particularly, but not only general practice, is lobbying very heavily that money should go into an increase in the rebate for primary care activities that occur in general practice. So CSF's position is that, yes, we think the freeze has been damaging, and we certainly see there's an argument that that rebate should increase. For us, it's the patient's rebate. So what we want to see is that people pay less for their healthcare. I suppose having had several children in childcare and watching governments increase subsidies to childcare and then watch my childcare out of pockets increase by the same amount, there's a little concern that increasing the rebate will not necessarily change the affordability issue. So what we want to see is people paying less for the healthcare. In particular, there are a few issues, a few areas that we think need to be funded in, along with whatever it is the government decides to fund with that 750 million. Some of that money should go towards a few things. One, and I'll start from the bottom up, really, because some of the comments that you've made in the Q&A today have been about how are we having a say, how are we actively involved. And so one of the things that I said regularly in the task force was that, you need to be asking Australians how they want the system to work and how is it working for them and what changes would they like. And that doesn't mean only asking people like those around the table, but asking a lot more Australians with very diverse experiences. And we'd like to be able to be funded to support consumers to be able to do that. That might be training them in skills in advocacy and even kind of media and goodness knows what else, so they can actually be active in lobbying and advocating for the change that they want for themselves and for their families and communities and so on. There's a huge amount of resources available to people who are involved in clinical professions when they want to engage in advocacy, but not necessarily the same is true for consumers. So we'd like to see some equity there. We also think that if the system is going to change, again, whatever that change is, maybe wraparound care comes in, maybe the fee-for-service model changes in some way, perhaps we have enrolment of people into practices, perhaps the digital mechanisms in place change, whatever it is, we all need to know about it. And we need to make sure that the health literacy resources are developed so that every Australian understands how the system works, how they can best get advantage from it. And we know that often those global campaigns with, the smiley face or the life be in it or the blue wobbly people or whatever the latest one happens to be, they tend to help those already with good health literacy to understand a change, but they're not as effective as helping others. So there's clearly a need for other mechanisms so that everybody understands any changes that come out of this work, this task force, and what it means for them as individuals. And finally, we want to see that consumers, the capacity of consumers is increased, not just as a response to the task force, but ongoing. Lived experience and peers are recognised to some extent in our mental health area, but not so much in other areas of the healthcare system, and particularly in policy development and funding decisions. So we'd like to really be able to improve the skills and the capacity and the awareness of the roles that health consumers can play in sitting at tables. I would have loved to be in a health task force meeting like this, where many of the seats were taken by health consumers. Indeed, I would have been happy not to be there at all, but to have other people there representing Australian consumers and talking about what it is that they wanted, all their families and friends wanted. That's the vision, to have many of us there, and over time, and that requires investment, so that we have people who are competent, are comfortable and are well supported to undertake key leadership roles as health consumers. So up between now and the budget, which is only a few weeks, we'll be advocating as an organisation very strongly for support for all of us in whatever changes the government chooses to make, however it chooses to spend the 750 million. Some of it needs to be to support all of us to understand those changes and to have key decision-making roles in how the services run out and what happens next. And we would love it if you would engage with us also in that, to encourage the voice of consumers to be loud in the weeks leading up to the budget.
Janelle Bowden's asked, is there any detail available on the Leadership Academy? Is there any public detail available yet?
No, not yet. We're working through that at the moment. We have worked in this space for a little while, thinking about what it might look like, but we haven't got a public document available at the moment, Janelle.
Okay. I think that we're going to a general question and answer, so I think most of the remaining questions probably would go to that section. So I don't think there's any other questions on this part. I think you've addressed those. So do you want me to just start going through some of the broader questions, or is there anything else you'd like to add in before we go to those?
No, I'm happy. I'm just looking on, and thanks, Anthony, for putting the task force members list there. I'll go and look later and see who I forgot to mention. I think we've covered off on most of the questions that people have asked in the chat, and happy for other questions that people have got. In the meanwhile, we might go to some of the other questions we got before the session, Jo.
Yeah, sure. I mean, I think one of the questions that comes up in the chat and in the questions that we received was the issue of workforce, and particularly the number of GPs, and did the task force discuss workforce at all, particularly the general practice workforce?
Yes, so and this was mentioned in one of the communiques that came out from the task force. So as we understand it, we have a maldistribution of GPs. That is, there is an argument made that it's not that we don't have enough, it's just that there are too many working too closely in big metropolitan cities on the eastern seaboard, and then not enough everywhere else. The challenge, of course, as well, you can't ask people to just move from wherever they live to another part of Australia to undertake their work, because often they have a whole life that sits around their work, family, friends, and all those other things that we all have. So we do understand that we have, in some disciplines, we have maybe not enough people practicing that discipline. In others, we have enough, but they're in the wrong places. Sometimes we have a workforce where people don't have necessarily all the skills that we need them to have. So we might have significant workforce, but they might not have the skills that the local community needs them to have. So yes, there was a bit of discussion about this, and one of the ideas behind a multidisciplinary care or just team care is that 3 heads are better than 1. So if you have a group of people who are responsible, again, particularly for people with significant comorbidities who need lots of support, then you've got a few people to work with that person, their family and care partners, and come up together with great plans and interventions to keep that person well and healthy, rather than a model where there's just one person making a decision.
In the questions that came in before, there was a sort of feeling from some of the questioners that this was looking like it was a sort of very one-size-fits-all approach, and not enough discussion in the admittedly short 12 pages, which is better than 210, I'd suggest, but in not enough about diversity and how models would be suited to particular groups, such as those who are bedridden, those who are housebound, perhaps older people who are living on aged care packages, and also around diversity and cultural safety. Was there discussion about having models that fitted particular cohorts?
Yeah, absolutely. There was a lot of discussion, people sharing from their own lived experience or from stories. And we had some people present during the time of the task force too, and they spoke about their experiences as well. There was absolutely conversation about diversity in the broadest kind of way that you can imagine. And part of the thinking behind wraparound care provided, in teams, is that those teams can be built up with the skills and expertise necessary for particular communities. And perhaps even some of these teams might be hybrid, so partly virtual, partly face-to-face. Perhaps they'll be all, in the one locale or one postcode. But the notion that a community might build with healthcare professionals, build the model of care, and that the models of care might vary from communities. What you might need in downtown Adelaide may be very different to what you need in Tennant Creek. And if the funding was provided and you could have the suitable workforce and other supports in place, then those models could flourish. Obviously, we don't want, well, my personal view is that there are some quality and safety issues and some consistency that needs to be applied, but I don't think that means that we need to get down into the weeds of exactly how a model should be. But you should expect that no matter where you live, the same kinds of services can be available to you depending on what your needs are. There was a lot of conversation about, how do we do this? I think there's a general view that communities and consumers actually often know what a great model would be like. And so how can we provide a funding model that allows them to actually work with their local health professionals to develop models that work in their local situation? So, in the best of possible worlds, this could be a really good thing. And I am an internal optimist. So, I hope we live in the best of all possible worlds.
Jackie Gibson raised particularly that there really wasn't much, she didn't feel there was much in it for Aboriginal and Torres Strait Islander people in terms of cultural safety, that the assumption seems to be that everybody goes to an Aboriginal service, and there, of course, there is services provided in a culturally safe way, but a lot of Aboriginal and Torres Strait Islander people don't go to those services. So was there any consideration given to encouraging or enforcing broader primary healthcare to be more aware of cultural safety and provision of services in that way?
So yeah, there were a couple of things. First of all, there was a conversation about how the models that are in place in Arches are often very good models, and learnings could come from those into mainstream services. So there was a recognition that there's a lot of good going on here. We should pay attention to it. I think there was also a conversation, and it's that fourth recommendation that talks about change management and culture, where there was a conversation about, and you can talk about the cultural safety for First Nations people, but we could talk about for people who are living with disability or for people who are gender diverse. There are all kinds of safety issues for people when they reach out for healthcare. We did discuss this. And we did say that, there were capacity issues here, and it was very important that our health professions were appropriately skilled so they could manage people's lived experience sensitively and provide, really good value care for people. So it was discussed. And again, it comes back to getting the right teams in place, having communities as well as the healthcare leaders coming up with something that'll work. And then it's that piece about consumer voice and accountability. If we're paying for it, either through our taxes or out of pocket, we all should be entitled to have a say in how it works. And, again, hopefully that's what comes from here.
And I mean, as a Victorian, you'll have some sympathy for this question, I guess. But, Victoria is quite well known for having good community health sector that is not sort of funded by the Commonwealth. It was built up by the state government and supported by that. Was there discussion about how those two parts of community-based primary healthcare would actually work together?
I think we had a lot of broad conversations about how in different parts of Australia, the system works differently. So you've got your federal overlay, and then you've got what might be funded by jurisdictions. Then you've also got what will be funded by, not-for-profits and other organisations. So we did talk about how it's not greenfields, nor is it one size fits all from state to state. And there was some conversation about, in the application of whatever comes next, having those conversations with jurisdictions about what already exists and how do we join this into that. And I think that's part of the reason why the Minister would have chosen to release this report at a National Cabinet meeting and have that early conversation with every state and territory about how we can make this, whatever comes next, be a part of the existing system rather than an add-on that's kind of like, pimple on the side that doesn't really really relate to existing really great practice, whether that is in Arches, whether it is in community health, whether it is in some other model.
There's quite a few people asking a question about whether preventive health was discussed and how did this work of this task force fit with the National Preventive Health Strategy. I wonder if you wanted to just talk a bit more about that.
Well, we did have a little, I can't remember which day it was on now, but I think, again, there is a mention of it in one of the communiques. We did talk about the importance of preventative health. We did talk about the fact that the multidisciplinary teams and allied health that are available in Australia do have expertise in preventative care, noting that there are lots of different parts to preventative care, health promotion a little bit different again, but there's a whole lot of things that our allied health professionals as well as other health professionals can provide support with. We also talked about how communities, carers and individuals can also be engaged in that and even lead some health prevention activities. So yeah, it was covered off, but again, I think there were the conversations about what our current fee-for-service model provides and what a wraparound model, which is, for want of a better word, provided a bucket of money to an organisation or group of people to deliver a service in a place, which could be virtual or could be, bricks and mortar, depending on the community, might do. And, you'd like to think that the dial would shift more to, not even the ambulance at the top of the cliff, but actually maybe a comfortable lounge chair several kilometres away from the cliff that would keep people well rather than get them to the edge of the cliff.
Was another question a couple of people and in the questions we got before was about the use of technology, and I suppose digital health, but general use of technology in delivering healthcare and in people looking after their own healthcare. Was there much discussion about the role of technology and technological innovation?
Look, there was a session on digital health and where it was a big topic, and I didn't go to that session. So I saw the communique and I was briefed about it. So I'm not the best person to ask about this. However, we certainly did in the other conversations, particularly, but not only related to two groups. Firstly, those that are in inaccessible areas, such as people in very remote areas. There were just conversations about how virtual care can be a great boon, recognising that not everyone wants virtual care for everything, but sometimes that's good and sometimes it's going to be the only thing that can be provided very quickly. We also talked about that when you don't have to be a long way from a metropolitan city for transport to be difficult. So if people can't get out of their homes, there's not good public transport, they've got other reasons why moving is not easy for them. Virtual care can be great there too. We talked about how it's more than, an e-script or something like that. All of us engage in health practices using technology. That might be that we watch a lifestyle show on the television. You might, like me, own an Apple Watch and close your rings every day. Perhaps there are other things that you use. Perhaps you've got a device that monitors your blood glucose. So we're all using digital health and other technologies in various ways to keep ourselves healthy. And, the usual conversation about these are all, built separately, proprietary, don't talk to each other. Not always the information is accessible either to the person using it or to their caregivers. This is a problem to be solved in the future, but certainly we saw the potential for digital health to improve access to services in some cases where it's difficult, to improve the sharing of information, which can be critical, particularly if someone is in a healthcare space which is not their usual space and people need to know quickly about their medications, their previous history, the capacity to bring specialist services into locations where there wouldn't be the demand for them to be there every day of the week, but where, their services would be greatly appreciated once in a while. So there was a conversation about that, not so much about innovation, more about how can we better use the things that are used now to support people to stay well.
And was there discussion, and this is a question that from somebody, an anonymous attendee, so I can't think of them, was there any discussion about the link between diagnostics and particularly pathology and point of care testing? Instead of somebody going off to the pathologist, they can have the test by the doctor and sometimes ultrasounds and things like that. Is that within the scope of wraparound care?
That may have been discussed on the session I missed, so I need to be careful there. But I do know that broadly the conversation about how can we better use technology occurred a number of times. I can't really comment about whether there was a deep dive into that particular aspect of point of care testing.
I think the rest of the comments in the questions and answer are really comments and people's concerns around management for chronic conditions. So I think they're reinforcing the focus of the task force and CHF's focus of, getting dealing with people with chronic conditions. And quite a few people, Sandy Robertson and others, stressing the need to get earlier intervention on chronic conditions. And I guess that fits with prevention and, other issues to stop people deteriorating. Just give everybody a call out if there's any last question that anybody would like to raise with us. Several people have got questions about the Leadership Academy, so we're obviously going to get, maybe when we've got further down the track, that will be the discussion, a future briefing for people on where we've got to with that. That would be just fantastic. We're really happy to have another conversation once that thinking is further advanced and we've got some funding to actually do that work. That would be really great. Christine's asked about multidisciplinary teams and self-advocacy more broadly. And I think, in the conversations certainly that I've had, even recently in the media with the department, our healthcare system is theoretically in crisis. I don't know exactly what that means. Crisis to me is kind of an unusual thing, but every day we're told it's a crisis. It kind of blurs after a while in some ways. But a lot of healthcare work is not done by health professionals. It's done by consumers, by families, carers, and the individuals themselves. And we strongly believe that we should all be empowered to look after ourselves as best we can through knowing what to do, being able to have conversations about our needs, have our needs heard and respected for our care needs, whatever they happen to be. And I'd hope that that whatever comes from the task force allows us, as all of us as health consumers, to be able to better do that. And it does, and if we can improve that, if we can all be more engaged in our healthcare, be better supported to look after ourselves well, then it does take pressure off the system. There's no doubt about that. The challenge is, of course, that not everyone will be able to do that. And some people will always need very intensive care. I think that's okay. We just need to provide that intensive care for those people that need it. But the more of us that can look after ourselves, whether it is through an app or a conversation on a phone or just information given through a community meeting, all of those things are really important. I would hope that some of what we do in consumer leadership will improve that, and we'll have consumer leaders who can also support other people to better understand our system. As much as anything, it's about navigating our system. There are lots of really good and freely available services, some of which are underutilised, but people don't necessarily know how to access them or even if they exist. So how do you know everything that's available in your local area? The reality is some will be funded by the federal government, some will be funded by the state government, some will be funded by a philanthropic, some might be funded by a local primary health network, some might be funded by some other organisation, local government. There isn't a directory that shows you where everything is, if they have availability, if there's a cost, if there's a waiting list, if you're eligible. All of this, this is to me is very basic, but as you know, very complex too. Even if we could just start by getting that bit right, to my end, that would be a really good outcome from this work, to really help consumers understand what they can access as a starting point as we go about the process. One hopes of reforming Medicare so that it is fit for this century, and moving forward does better and better for everyone, because that's what we want, a system that works with us. It probably relates quite well to the last question by Kerry, which you talked to when you talked about the three things that CHF was going to do. One of them was about improving health literacy, and Kerry's making the comment that she didn't feel the report gave a very high priority to improving health literacy and making sure information is provided to people in a way that they understand. Do you think there is an appetite for doing something about improving health literacy?
Well, then we get into the social determinants of health, don't we? So I think education is the most powerful social determinant. And I think that people who don't have good digital health literacy as a part of their education will increasingly be marginalised because of the way that our society is broadly relying more heavily on technology, which means that now you often need to be able to read and write. Because it's not a conversation with somebody where they might explain things to you in a different language, or their body language might help you understand, or if the accessibility might be better for you if things are done face-to-face rather than mediated through some kind of technology. So I think this is really important, and I do get concerned that as we move towards the digitisation more broadly of our community and the impact of that on health, is that we do increase the divide between those that are digitally savvy. And people often talk about age, but age is not the only reason why people can and can't use technology, as you would all well know, and what that might mean for people, and how are we making sure that there's a non-digital mechanism for people who cannot engage in that way or choose not to, because we have the right not to choose, right to choose not to engage in that way too if we want. So I think that is important. And I think in a previous role, I looked after an area of a local government area where there were 200 languages spoken. So even just getting the language bit right is tricky. And many people in that community did not speak English, so did not read or write in their own first language. So it's not even about translating. And a digital mechanism may be helpful. For example, videos of community leaders speaking in language about an issue could be really great and help people. But then that's a lot of videos, and it does rely on, again, technology, which may or may not be accessible. So, for me, this is important. It's not like we can no longer be digital as a society. I think that's just going to keep coming. But I think there's an equity issue here, and I think we all need to be aware of it and keep talking about the importance of making sure that we bring everyone in an equitable way forward into the future and not leave some people behind.
So I think that's all the questions. So did you want anything final that you're going to say to people?
I would just like to say thank you to everyone for attending. There's many people on the call today, and I appreciate your time. I hope that this was of some value to you. I love your comments in the chat about, what was useful or not useful. If we didn't meet your expectations, if you wanted something different or you want something more from us. I know some have said they're really interested in the work on consumer leadership. I've heard that. And when we can, we'll make sure that we publicly talk about what that might look like. Always good to get feedback in a room. I can tell just by looking at you, shaking your head at me or smiling that this was useful. So please send that along. Also, the next steps for us is, and we encourage you to follow us. We do almost everything. Be pleased to know I don't post my lunch on Instagram, but we do talk, particularly in LinkedIn and Facebook. So LinkedIn and Twitter, and we're probably most active. We're a little active in some of the other platforms as well. Do follow us, then you'll know what we're doing. You can also go to our website and become a subscriber to our newsletters and so on, if you want to know what's happening with CHF. And we will be coming back to you all and saying, okay, this is really the ask for the federal government. We know that our clinical colleagues are very active, and quite frankly, they have a lot more money and influence collectively than it might appear that Australian consumers have, and are able to very successfully lobby government. Again, only look at all the conversation post the task force and how little has been about what Australian citizens want and need from their government in relation to health. We'd love you to all join us in really amplifying the views of Australians, what change they want, the frustration some of you have expressed in your questions. I hear you. So let's make sure that we actually make sure that is about that's heard at the highest level, so people understand what it is that we want. If we don't say it, they don't know about it, right? Again, thank you so much all for joining. Love your questions. Look forward to doing this again with you soon. We'll certainly post-budget. We have a post-budget briefing and we'll be talking about this in more detail and hopefully be very happy with what we see. Until then, I hope you all stay well. Thank you.